Ladies and gentlemen, please welcome to the stage Dr. Kimberly Schlam.
All right, well, so nice to see you all today. I have a private practice in Bend, Oregon, and today I'm here to talk to you about the existing dental implant, on when to revise or remove it, and hopefully help you win Monday.
For some reason, when my finals went in, it was like these are my teeth. They were just mine. Like, I don't know how else to explain that, but like, they're mine. They're my teeth.
Now, dental implants are no doubt life-changing, right? Patients sometimes go through months, if not years, of surgical and prosthetic work to achieve a result that feels like part of them again. You heard from Nicole, it feels like part of her. Now, I love dental implants because of the innovation. With this innovation, we can provide an exceptional patient experience and extremely predictable results. At our office, Bend Prosthodontics, we love SmileCloud. We love virtual surgical planning. We like to use the CBCT, intraoral scanning, photogrammetry. And with this, we get to connect with our patients. You learn at Spears something called co-discovery. Frank's talked about it for a long time, and the ability to use these visual tools to connect with our patients. And so with this technology, I'm able to see the end before I begin, and I can achieve it consistently. So as many of you know, I love to travel and teach internationally on the latest and greatest of implant technology, right? How do we place more implants? But what's missing from our education is how to manage dental implants, how to manage complications, right? Anybody have a great journal for that? So what do we do when we need to revise them over time? So take a look at my practice. I do a ton of revisions. I'm a boutique referral-based practice. If you were to look at that, it's about 40% of my patients for revision cases have some sort of existing implant, whether it's one or two or more. So our dilemma lies in the fact that patients think implants are more predictable than teeth. But us clinicians understand that there are significant biologic and functional differences between teeth and implants that make them much less predictable. Seasoned clinicians have described implant revisions as a type of gymnastics, where we have to play this game, a multidisciplinary approach to try to solve this, oftentimes with limited results, right? We're not able to achieve that same aesthetic that we started out with in our first attempt. And there's no great consensus in the literature. Many clinicians have spent their entire career trying to understand how do we manage this, right? You heard some incredible lectures this week about how do we fix the soft tissue, how do we deal with the hard tissue complications, and then how do we mask some of this prosthetically. But I'd say with all of that, we don't have a lot of solutions, but these providers, these are the ones I love to follow. They're looking at dental implants in the fourth dimension. They're looking at them over time. So I have to go back to my practice like you do on Monday and figure out what the heck to do with these patients. So I came up with a practical three-step approach that hopefully you can apply for your patients. And when you look them in the eye, have a rational decision on how you're going to go about using an existing implant. So step one, can you identify that implant and source the parts? Will keeping it continue to cause harm? Does it support the desired future prosthetic plan? So number one, my team likes to call these the UIDs, right? Not UFOs, but UIDs, unidentified implanted devices. Anybody have those in their practice? Of course you do, because this has become a huge professional issue for us, right? There's more than 4,000 brands and models of implants out there with all different types of drivers and parts and pieces that are needing to be used. This is a problem for us. And so I've spent a lot of my career trying to figure out the best ways to identify them. Many of you have heard of what implant is that, or maybe you send your radiograph into Preet, or you send them to your implant rep, and that all used to be free and fun and dandy, but it's not anymore, right? Because they're like, oh my gosh, I'm getting inundated with all these radiographs. So how are we identifying them? So my team has settled on using Spot Implant, and no, I'm not paid by them, but I would recommend checking it out. It's a service you can pay for, and I get 2 identifications per month. And with that, we're harnessing AI. You heard all about AI and the amazing things about it, but AI can learn things like thread pitch through this deep neural network learning. And it can actually spit out a percentage of what these different implant likely is, because how expensive it is to order all these parts and pieces and then attempt to be able to restore them. But we need to stop the bleeding, literally, right? This is a problem. Let's stop doing this to each other. We are all colleagues here. My patient might end up in your chair, right? And how are you going to manage that in the future? We have better ways. This is our professional duty to start storing this information on both the prosthetic and implant parts that we're putting in our patients. Right? If you have a patient with a lot of different types of implants, which I often have, you can use this resource, ID2, to store all of that data for your patient and put it in the cloud and hand them a nice little card and say, here's the gift of your information. When you end up in another state, just give this to your doctor and they can figure it out, right? Also, if you're placing new implants, many of the implant companies have realized this is such a problem, and so Straumann has something called the Implant Registry, where at the time of placement, you can scan a code on your phone and store both prosthetic and surgical components, and also track the data in your practice over time. Wouldn't it be nice to see where your failures are? Are they patients with diabetes, or maybe did we make a bad treatment planning decision for that patient? So if we can identify that implant, now we can keep going. Is it going to cause harm in the adjacent area, or is it stable? So when we talk about stability of implants, it's just like stability of teeth, right? Periodontal disease and peri-implant diseases are not contained. They affect everything around them. So is this implant stable, or does it have the potential to cause future harm? And you all know what I'm talking about with that. I could have a whole lecture on that. So if it's stable and it's not causing adjacent harm, now we can consider the ability to use it in a new future restoration. So when it comes to a new prosthetic plan, I like to talk to my patients about an existing house. Some of you have an existing house and that actual foundation of the house is still good. If it's still good, we can continue to use it, right? But with a single implant that our patient might have, right, we can use that for a new single restoration. We can attach it for a bridge. We can do a full arch restoration. So all kinds of things we can do with it. But our implants have two ways to function. They can either support our new prosthetic plan, or they can get the heck out of the way. We can bury it, right? If they don't do either of those things, we need to take it out. So let's take a look at this first case, site number 7. This is a patient that presents, as you can see, with an external hex implant. And when we look a little bit deeper, we can see she has some other anterior aesthetic needs. Now, what if I told you that this was the 3rd revision of that implant, right? We start to reconsider whether or not we would attempt and be that hero for that patient, right? Maybe there's something else going on. Maybe that implant is not deep enough. There's probably not new availability of zirconia abutments. So for this patient, we need to start considering, do we actually move the whole block of bone and implant, or do we take it out of there and get it out of our way? So this patient's not doing a whole lot for, this implant's not doing a whole lot for our patient, so she's decided to take it out. And as you can see, she also chose, because I used some good visual aids, to proceed with the additional dentistry that we talked about. And so she did some slenderizing of her existing restorations, some orthodontics, and she's actually headed up to Jim Janikowski to have that implant removed, some augmentation done. I did some composites to kind of help guide us for the future orthodontics and definitive restorations. But once we get that all done, we can get her back on track. But do you think she wants a new implant? Probably not. You heard from Greg this morning how wonderful this other option is, particularly in our anterior young patients, right? She thought this implant was going to last forever and it was going to be amazing, but it wasn't. So she doesn't want to set herself up for future failure, so she went ahead and decided to do a one-wing resin restoration there. So taking a look at our next case, we want to take a look at how we can use implants for a full arch restoration. I know I see a lot of clinicians, they say, oh, let's wipe everything and start new. I don't necessarily think that's the solution for all of our patients. If those implants are healthy, why can't we consider using them? Even for our digital processes, right? If we can have the ability to adapt to those existing implants, then we're not creating new future holes in the bone. So this patient, as you can see, he had several tooth-borne restorations that were failing, and we want to consider using them for new implant prosthetics. So again, he's had several rounds of tooth-borne restorations. As you can see, maybe he wasn't opened up vertically enough, maybe he's had some wear and tear, but for whatever reason, he does not have a lot of tooth structure remaining underneath these teeth, although I wish I could have used them. So with that, we want to go ahead and think about our algorithm that I described. Can you identify them and source the parts? Will it continue to cause harm if I keep them there? And then does it support the desired future prosthetic plan that we'd like to use? So taking a look at this, you can see, you heard about FP1, FP3 a little bit this week, But that's kind of my world that I live in, and if we have an existing implant that was placed for a single or a bridge tooth-borne restoration, I can consider using that for an FP3. So that's what we did for him. As you can see, we had several older tissue-level Straumann implants that we were able to use. We had an old Megagen implant, and then I went ahead and placed some new Straumann, I shouldn't say I, my team, placed some new BLC implants. And we used SmileCloud, we did a whole virtual workup, and had a really incredible result and maintained a lot of healthy structure. So I would say I get to do a lot of implants. I get to do a lot of dentistry. I feel blessed. I have an amazing team. But implant dentistry is no longer about placement. It's about stewardship. Let that sink in for a moment. This is the most important slide. Implants may not be forever, but good decision making should be. So with that, please follow me. I put a lot of content online, and I really appreciate your time today.